Hello everyone, Kent.Bressler here. I want to welcome you to Kent's Kidney Stories. During our time together over these podcasts, I'd like to discuss kidney disease. I'd like to tell you about my journey as a transplant patient, but also talk about dialysis, kidney donation, and just about anything else that might be of interest. Kent's Kidney Stories, podcast endorsed and sponsored by kidneysolutions.org. Good morning, everyone, or evening, or afternoon, or whatever night, and whatever you're listening to this podcast. It's Kent.Bressler, and that's exactly what we're going to do this morning. We're going to take some time. This is my birthday, so I get to do what I want to do, when I want to do it, and I usually bring on really good people on my birthday. They're all good people, but this guy's an exceptionally good person, and I'm going to introduce him here in a few minutes. I wanted to tell you that if you haven't gotten your immunization for COVID and you're a transplant patient, make sure you talk to your nephrologist or the transplant community and get their ideas on it. But remember, it's your choice. It's your life. You're the one that's in charge. So I say this to get your attention, not to advise you or get you into a situation you don't want to be in. But talk to your doctor. That's who you need to talk to. You don't need to listen on the internet or listen into somebody else's opinion. Talk to your doctor. Get his opinion, and then you make your decision. That being said, on my birthday, I'm going to introduce a very good friend of mine. We haven't been friends long, but it seems like it's a privilege and an honor just to be around him. His name is Dr. Eliot Heher, Heher, and he's from Boston. Good morning, Eliot.
Good morning, Kent.
It's great to have you. I'm looking forward to this.
Me as well. It's my privilege to be with you, and so respect the work that you're doing, and the listeners and the patients that you're the big community in transplant related folks that listen in, and it's my privilege to be here.
We started this whole thing from my daughter. She said, hey Dad, you love to talk and you're good at it and you can do a lot of it. And why don't you talk about kidneys? Because that's what you know a whole lot about. And when I started, I was trying to, come up with that sessions every once in a while about kidney disease. And then I started working the idea that it's not all about me. Let's get some people in here who really know what's going on. And so I've been doing that over the course, and I'm really looking forward to this one.
And happy birthday, by the way. Happy 39th.
Yeah. 39th. I'm in my 7th decade, and let me tell you, I'm very happy to be here. I don't think there's a better alternative than to be here serving the Lord and also working really hard with kidney patients. That's all I asked to do, and that's all I'm going to do till the end. So now it's enough about me. Dadgummit, give me some background. Tell me about yourself. Just give me some background.
Yeah, of course. So I live outside of Boston now, but I was raised in New Jersey in the center part of the state near Princeton. Always liked science and had some doctors on my mom's side of the family. My dad's mom was an ophthalmologist. My mom's dad was an ophthalmologist, and one of her brothers was an ophthalmologist. She had another brother who was a scientist. So I took pretty early to science and pursued medical school after college, both at Harvard, and then did my residency in internal medicine at Johns Hopkins in Baltimore.
Yay.
So nephrology and kidney medicine appealed to me starting in medical school. We had a great second year experience in what's called pathophysiology, which is the first year of medical school is a lot about the normal human body, and the second year of medical school is a lot about what it's like when things aren't going well with the body. And it's broken up generally into organ systems. So you study the heart and the lungs, and you study the kidneys. And I just was fascinated by the kidneys. That was my entry point into it.
So you're actually a transplant nephrologist. There is a significant difference here, and I want you to explain that to the group that's listening this morning, or who will listen.
Sure. So nephrology as a specialty has been around for probably 50 or 60 years. It may have been the cardiologists may have been the first ones looking after the kidneys. But for many, many years, before dialysis, nephrology concerned itself, of course, with treating kidney disease and the management of abnormal electrolytes, salts in the blood. And then when dialysis and transplant began to emerge, the focus of the field changed towards managing those two treatments for kidney failure. But in the early years, the 50s and the 60s and the 70s, really through the mid-80s, transplant was extremely rare, whereas dialysis grew significantly during those decades. And the field of nephrology became a little bit more focused on just on a numeric basis on dialysis than on transplant. And then with the availability of cyclosporin in the mid-80s, transplant began to grow. And the success rates increased dramatically. The rejection rates fell dramatically. And then over the course of the next 10, 20 years, really, transplantation became more and more successful, but also more and more complex. So in the early years, everyone with a transplant took Imuran and prednisone. And then after the mid-80s, everyone was on cyclosporin, Imuran, and prednisone. And now there's a dozen or more medications, 24, that are a part of regular transplant nephrology practice. So it became pretty apparent that there needed to be a subspecialty within nephrology to focus on the care of the kidney transplant patient. And that's really how the subspecialty transplant nephrology evolved. And there are now, as of the last 10, 15 years or so, there are dedicated training programs so that after a physician completes their internal medicine residency and then completes a nephrology fellowship, they can get an additional year of training in transplant nephrology if they choose. There are certainly the additional training is not required. The formal training takes a lot of training, but you can do that on the job, as it were. And there are a lot of excellent transplant nephrologists in practice who did not have a transplant nephrology fellowship.
That's significant for the listeners because you have a nephrologist and then you go into transplant and you wake up and you got another nephrologist, totally different.
It is.
That's that transplant specialist that you're talking about.
And of course, with nothing in life is free, and there are certainly advantages to having subspecialization. Allows people to maintain and will obtain and then maintain a particular expertise, and allows them to practice at a higher level. On the other hand, the downside is that there is this transfer of care. And,
yes.
And that, of course, often happens to patients when they have chronic kidney disease and they transition to dialysis, because they often may have been seeing one nephrologist, but then they see a different nephrologist who goes to the dialysis unit near their house. And that's really disruptive and unfortunate, but often unavoidable. And then sometimes that same transition can happen after someone gets a transplant, where they're transferring their care to a transplant nephrologist. Most transplant nephrologists, though, work in tandem with community
Absolutely.
and general nephrologists. And I always tell my patients that the dream team after you've had a kidney transplant is to have a transplant nephrologist, a relationship with the transplant center. That should be forever. Also a relationship with your prior general nephrologist and a relationship with a primary care physician. That having those three physicians involved is really the dream team for post-transplant care.
So now comes my big question to you, because I know you well enough now, and we've been doing some things together that I'm really excited about. What is your take on dialysis versus transplant first? What is your feeling there?
I feel very strongly that transplant should be the first option that's considered for everyone who is facing the possibility possibility of kidney failure. Not everyone will qualify or benefit from a transplant, but I think it's critical that that first question be asked. That the first question that's asked is what is the best therapy, and that transplant should be considered first. And of course, within transplant, we have two different types of transplant. We have deceased donor transplant and we have living donor transplant, two different sources of the kidneys. And there's also no question that living donor transplant is the preferred therapy if it's for the vast majority of patients. I'd given, for several years, I gave a talk to a large group of nephrologists who were attending a board review course. So this was a room at a hotel in Boston with 150, 200 nephrologists all studying for the boards. And I gave a talk on living donation. And I started the talk by asking for a show of hands from all these doctors in the room, all these nephrologists. If you yourself were facing the possibility of kidney failure, how would you want that kidney failure treated? Show of hands. And the first option I gave them was dialysis for the rest of your life. And never once in the years I gave that talk did a single hand go up in the room.
And these were all nephrologists.
All nephrologists. The second option I gave them was dialysis for a period of months or years, followed by a deceased donor kidney transplant. And in a single year, a single hand went up in favor of that option. And in the third option I gave is living donor kidney transplantation performed before any dialysis is necessary. And every hand in the room went up. So it's what nephrologists would want for themselves and want for their loved ones. And thus it's what we should want for all our patients.
I'm just shocked. I mean, I understand that whole process, but to me, it's always been that way. I never did want to go through dialysis. I knew what dialysis was all about, and bless those folks that are on it, okay? I understand where they're at, and I understand there's, some issues that come up where you don't get exposed to transplant right off, but that needs to change. That should be one of the first things that happens.
Dialysis is a miracle. It's been termed the most effective medical therapy ever devised, in the sense that every person who is in advanced kidney failure will die of it if they do not get treated, and that dialysis will allow them to live. There's the WHO has estimated that around the world there are tens of millions of people, at least millions of people, who die every year from untreated kidney failure because they live in a place that doesn't have the resources or the commitment to public health to provide dialysis or transplantation. But that said, dialysis it takes a lot away from you. And the longer you're on it, the more it takes from you. A day, a week, a month, okay. But months or years of dialysis not only takes away the quality of your life, but it solves some problems, but it creates others. And people begin to develop complications related to the therapy or related to the insufficiency of the therapy.
The argument then would be, if dialysis has its problems, so does transplant.
Yeah, indeed. And of course, one of the major problems, and often people come to the discussion with a concern about the availability of living donors. And certainly no transplant can be performed without a kidney. You need a donor.
Yeah, right.
But I think that the unavailability of living donors is often used as a paralyzing explanation. People say, sometimes when people are faced with a complex problem, if there's reluctance to really address it, they'll throw out a reason for the problem that they believe cannot be solved and then walk away. And in kidney medicine, I think that's done when people say, the problem is that we don't have enough kidneys. And then they'll walk away from thinking through the problem. And I think that's a problem that can be addressed. And I think the work that you're doing is a wonderful example of how it can be addressed. The critical first step is that recipients need to know about transplant. They need to know about the advantages. of transplant compared to dialysis. They need to know early in the course of in their disease, before they begin to feel very tired and washed out, before they start dialysis, which in and of itself becomes a part-time job with no pay and no vacations. It makes it difficult for them to focus on other things. And they need to begin a donor search, and they need support as they begin to search for living donors. If you don't know you're a kidney transplant candidate, you don't know, first of all, the kidney transplant is good for you. And secondly, that you don't know that you're a candidate, then you don't begin to search for a donor. Right. You don't ask your friends and your family and your acquaintances. So job one is to start with the recipient and have a discussion about the advantages of transplant, and then assess them and evaluate them for transplant. And then job two follows very naturally from that, and that's the search for a living donor and supporting both the recipient in the search and the donor candidates who step forward, supporting them in their desire to be helpful.
I think that's the most important thing, is to start early. We know that. I mean, it doesn't take rocket scientists to figure out that the sooner you know about a process that can kill you, the better off you are dealing with it. And there shouldn't be any fear in that. A physician should not say, well, I don't want to scare them. You don't scare anyone. You scare them if you don't give them some knowledge and some options.
I agree. I think there is a wishful thinking that goes into the care of patients with advancing chronic kidney disease, where the GFR, for those who aren't familiar, of course, the creatinine is a blood test, and then the creatinine and a few other pieces of data go in to calculate the GFR, which is your level of filtration of kidney function. And normal is about 100 or more than 100. And when you're down in the single digits, you almost certainly need dialysis or a transplant. So most people with chronic kidney disease, they can follow their progress or the decline of their kidney function by following that GFR. And I think of it as like an altitude on an airplane. You want to be as high as you can. That's the safest place to fly. If you're down to 10 or 9 or 8, you're pretty close to hitting the trees. Hitting the trees being kidney failure. And
yeah.
All the guidelines say that when you hit 30, you should have a discussion about the treatment options for kidney failure. Because the simple fact is, no matter how you get to 30, whether it's diabetes or polycystic kidney disease or one of the other many rare conditions that can affect kidney function, if you get to 30 or below, you're kind of at the point of no return. And most of the time, if you live long enough, you will develop kidney failure. Not always, but most of the time. And so that's the point where you have to stop thinking about what the cause was, and you have to start thinking about, well, what are we going to do about it? But unfortunately, as I say, there's a lot of wishful thinking that 30 will stay 30, will stay 30. And then it becomes 29 and then 28. And people say, well, 28 is pretty close to 30.
Yeah.
And then it's 26. And you say, well, 26 is pretty close to 28. Well, before you know it, you're down to 19. You're beginning to feel fatigued.
And you haven't started your search.
You haven't started. And you've lost a year or 2 or 3.
Yep.
Couldn't agree more. An early start's critical.
And the sooner the better. The early start makes the difference between finding a donor and having somebody call you and say, hey, this guy's in the intensive care unit and he's searching for a donor. We hope to get him out of the unit in the next couple of days. That's not the time to start. That person needs to be on dialysis. That person needs to be safely on dialysis for a bridge for getting ready for transplant.
Sure.
There are, but the sooner the better.
Sure. They've crashed into dialysis, as you said.
Yeah, absolutely.
They have a medical complication from advanced kidney failure that needs to be treated on an emergency basis with dialysis, and that will take weeks or more for them to recover to the point where they can begin a search. Much less
if they can.
If they can.
To be honest with you, sometimes people just don't recover. They get so far down in their GFR, and if they're not on some type of replacement therapy, they're not going to make it. So that brings it to the dialysis, kidney transplant, or death. I mean, where is there any other option?
Those are the choices, and there are also there's the option where people are on dialysis, but they have a problem, and often these problems develop while people are on dialysis that prevents them being a kidney transplant patient. And the longer you're on dialysis, the more likely it is that opportunity for transplant will close. I used to, the Humpty Dumpty. I used to, of course, we all wondered what that means, right? Humpty Dumpty falls and breaks, and all the king's horses and all the king's men can't put Humpty Dumpty back together again. Well, in practicing medicine, I've concluded that a Humpty Dumpty problem is a problem that you just can't put the pieces back together again. And over the years of practicing, I concluded that's one of the really most important things that doctors need to do is protect patients from Humpty Dumpty problems, things that can't be put back together again. There are things that can be treated, pneumonia with antibiotics, and you recover completely. But there are other things that can't be corrected. And the longer you're on dialysis, the more likely you are to develop a Humpty Dumpty type problem that no one can fix and make you a transplant candidate again. And that the earlier you start in planning for transplant and looking for a donor, the more likely it is that you actually qualify. And the later you start, the more likely it is that you develop the problem that can't be corrected and prevents you from being a transplant candidate. So that's another reason too.
Yeah, that's a whole nother discussion, because we know that long-term dialysis, just like life, it accelerates actually the process of losing organ function. It damages everything in your system, regardless. I know it keeps you alive. I understand that. I get it, but it has a significant impact on your health.
That's correct. Couldn't agree more. The longer you're on it, the more it takes away from you. And one of the major problems is the hardening of the blood vessels that comes from abnormal metabolism of calcium and phosphate. And when your blood vessels are hardened, then the heart gets impacted. It has profound effects on all parts of our physiology.
I can tell you, if I hadn't had Mulgrew when I started, I would have wished for you. You're a fantastic person, believe me.
Dr. Mulgrew had the foresight to understand these things before they were really apparent, 40 years ago. And it's really interesting how, even when I was in medical school and residency, I'm 57, so I was in medical school in the late 80s and residency in the early 90s. And it really seemed like it was a toss-up between transplant and dialysis, that they were both reasonable options. But the people who were really paying attention could see that transplant was pulling ahead. And then there was this really famous publication, New England Journal of Medicine, in 1993. And what was critical about that was that they compared patients who were transplanted to patients who remained on the waiting list. And that's when they found dramatic improvements in life expectancy. Before that, people would say, well, transplant patients live longer because they're healthier at baseline. It wasn't the transplant that did it. Right. They were healthier before. But that study resolved that question, or resolved that methodologic issue, and proved without a doubt that patients who receive a transplant live longer. And now the statistics would show that regardless of your age, if you receive a transplant, even a deceased donor transplant, you double your life expectancy. And if you receive a living donor transplant, your life expectancy goes up even more. And of course, from the point of view of quality of life, patients who receive transplants are much happier than patients who remain on dialysis. Women who receive transplants can have babies very easily. Young babies, kids who get transplants grow normally. They get back on their growth curves after a transplant. It's really incredible. Of course, Alonzo Mourning won an NBA championship as a kidney transplant recipient. He's not a patient of mine. That was reported in the news. There's no limit to what transplant recipients can do. They can achieve at the highest levels of human capacity.
Given the fact that I'm 71 years old and I've had my kidney for 33 years, one of the things, well, actually, I've had my brother's kidney for 33 years. And one of the things that I've noticed when I read all this stuff on the internet is, oh, gee whiz, so many people wait until their GFR gets down in 3 and 4. And, they're trying to figure out what to do. Should I go on dialysis? And I think that's tragic, because this GFR decline is not a measuring stick to see how low you can get, right?
That's correct. And the other phenomenon is that while the GFR may fall at a steady rate for a period of time during your disease, then it might fall much more steeply and much more acutely. And it's very difficult to predict those events. And the way I describe it to patients is that your falling GFR is a little bit like the trees in the autumn, where the nights are turning cool and they gradually turn from green to yellow and then from yellow to brown. And then a couple of them will fall off. You'll see a few of them below the trunk of the tree and they gradually fall off. But then one day there's a storm that comes through, a big October wind and rain storm, and it knocks most of the leaves off in a single night. And that storm, of course, was completely unpredictable. If you tried to say, well, what day will I need to rake up all my leaves? Well, you can't predict it because you didn't know when that storm was coming through. And that same phenomenon can happen with patients who have decline. It can fall slowly and in a measurable way, and it can seem like it's in control. And then a storm can come through. And what would a storm be for a patient with advanced kidney failure? Well, it could be COVID. It could be pneumonia. It could be the flu. It could be an infection of their foot. It could be sepsis. Almost any number of other medical issues can take someone with reduced kidney function, someone with a lot of yellow and brown leaves, and knock them all off and put them into kidney failure where they need to start dialysis immediately. And that's another reason why you need to plan, so that you're prepared for those unexpected events that can come up out of nowhere.
Another thing you hear a lot is, well, I feel fine. I'm just fine. You know, here I am at 19, or here I am at 12, or, you know, or here I am at 3. I feel fine. Your body is it's a human functioning object that adapts to everything, and it's going to continue to adapt. And one of the things is your body adapts to all of this adversity. And you just kind of learn how to go with the flow. Your body goes with the flow, and so do you. But still, the damage is being done.
It's a blessing, those periods when people feel well at the low levels, and it's a testament to their courage, and it's a testament to people's fortitude. It's often a testament to their support system, their spouse or their friends or family are supporting them. But to use a similar analogy, it's a little bit like a summer day, or a sunny day, I should say, where the radio says there's a hurricane on the way. And of course, you're hoping to heck that the hurricane veers off back into the ocean and never comes and hits you. And no one can predict the future. If you're sitting with a GFR of 19, no one knows what's going to happen next. You can only play the odds. But if the radio says the hurricane's coming, well, wouldn't you spend some time, even though it's a sunny day, getting ready? Pull in the porch furniture, put the car in the car park, or drive.
Shutter the windows.
Shutter the windows.
Yep.
Even consider driving 6-8 hours north to your cousin or your brother's house and sheltering out there just in case it does hit. It's common sense, and that's a similar situation with advanced kidney disease. You want to take advantage of those sunny days to prepare. Of course, you're hoping and praying that the storm doesn't come, but it makes sense to plan ahead.
I know for fact, because I'm involved in it, that you have a plan to work early on and get people transplanted before they even go on dialysis. I know that for fact. And I understand it because I believe in it. And that's the only thing actually I believe in the kidney world anymore, is the fact that we need to get more people preemptively transplanted. Okay. I think the key to success to getting the numbers down. Explain just a little bit about your idea about preemptive transplant, or, you know, transplant first. Give me your feelings.
Yeah, sure. So we've talked about the advantages of kidney transplant, and particularly transplant performed before dialysis. So unfortunately, as you pointed out, we don't do enough of those in the United States. So for the last 20 years, only about 2 to 3% of Americans who develop kidney failure every year receive a transplant as their first therapy. And so the fundamental premise of my organization, which is called Square Knot Health, square knot being a surgical knot, reflecting the fact that surgery is the best treatment for kidney failure, the fundamental goal of Square Knot Health is to get that number, 2 to 3% of patients receiving a transplant as their first therapy, getting that number up as high as possible. Now, I'm not naive. We'd never be able to treat 100% of patients with a kidney transplant as their initial therapy. But I do believe that we can do better in America than 2 to 3%. And so then the question is asking, okay, why is it only 2 to 3%? What are the barriers that are preventing that number from being higher? And the first barrier, as I mentioned earlier, of course, that people come up with is well, there aren't enough kidneys to go around. And sure, we've got to address how we find donors. But that's a problem that, like many of the other barriers, can be addressed. But what are the other barriers? Well, you mentioned a couple. One is that we don't start talking about it early enough. So we need to break that down. We need to get to patients earlier in the course of disease, and we need to make transplant education available to them. But secondly, in my mind, education and assessment or evaluation for transplant go hand in hand, because everyone qualifies for dialysis, but not everyone qualifies for transplant. So it's very hard to focus on transplant until you know whether you yourself are a candidate. And there's a lot of misinformation about whether or not you're a candidate. People think that sometimes that any kind of cancer might prevent you from being a transplant recipient. But most skin cancer, for example, would not prevent you from being a transplant recipient. Many prostate cancers would not prevent you from being a transplant candidate. And many cancers, if 2 to 5 years have gone by, almost all other cancers, you're good to go. And so educating early, but also assessing people early, taking a careful look at their own medical history and talking to them, and assessing and getting them a really clear idea whether it looks like transplant would be the best choice for them, getting that decision made earlier. That's another barrier that we need to address. And then once those two steps have been made, discussion about living donation and who might be a living donor and who might not be. There's a lot of belief that donors need to be matched to you in some way. And certainly in the early days of transplant in the 1950s, of course, the first successful transplant was performed between two identical twins.
Yeah.
Because the anti-rejection medicines weren't strong enough. And so they had to be perfectly genetically identical for that transplant to take. And over the time that evolved, and so that a brother, a sister, or a parent could donate. But the fact is, in 2021, any living donor kidney from a healthy, willing donor has the chance of surviving, equal chance of surviving as almost any other donor kidney, with the single exception of a perfect match sibling. So the search for a living donor now is not the search for someone who, quote unquote, matches you. It's the search for someone who is healthy and willing. Yeah. And that's the message that needs to go out to people who are looking at the possibility of kidney failure. That
in itself is the best statement that I've heard in my entire life. It's great. This whole concept, I love the concept, and I know that this is going to be something that comes. It's going to come pretty quick. I think fast. It's going to get more accelerated. And your idea, this concept that you have, is right in the ballpark. It's the field of dreams that people talk about. All right. And I'm all in this for you. I want you to do this. I want you to just keep drilling. You know what I mean? Just keep working at it.
We've been so blessed to meet you and to hear the work of Kidney Solutions. And we, as you mentioned at the start of the podcast, we haven't known each other a long time, but it feels a lot longer than it is, because right from the start, we realized that our vision and our perspective on kidney failure and patients with chronic kidney disease were identical. And I love the fact that we were introduced by another patient.
Exactly.
And
mention her name.
Amanda Grandinetti. And we, I think one of the great steps forward in medicine that is still evolving, and still progress is still needed, but the involvement of patients in planning clinical trials and in patient advocacy groups and all the work that patients are doing on behalf of the field and behalf of other patients who are to try and make things better for the people who are coming along. Exactly. I think it's been such a step forward, and you're an example, and Amanda is an example, and And we're really excited to include in Square Knot Health as many kidney transplant recipients, dialysis patients, patients with family members, patients with personal experience with kidney disease. We really want to build our employee base with folks like that, because there's nothing like going through things to understand how they can be better. And there's nothing like going through things yourself or a family member to have a passion to making things better for the people who are coming along.
When this all starts developing, I'm going to have you back, and you're going to explain just the concept of a square knot. And at that point in time, that discussion that we will have is going to be worth it to all those people that are coming.
Let's do it.
All right.
Can't wait. Can't wait.
Okay. Thank you so much, Dr. Heher. Thank you. I just appreciate you so much. You just don't know how much.
It's my pleasure, and the feeling's mutual. You're doing fantastic work on behalf of patients, and I'm so grateful that we met, and so happy that we'll be staying close touch going forward.
Okay, folks, you've heard this podcast, and I just want you to go back and listen to it again. He dropped some really interesting topics on you, but the most important thing is his heart. The heart that he has to help people and the willingness to start early is significant. So take just a little time and share this with as many people as you can. It's a very important podcast, and I hope we can get it out to everyone that's on your list, people that you know, family. Let's find some more living donors, and let's cut this wait time down. Let's get people transplanted. Okay, that's all I got to say. This is a great podcast. This is a great man, and this is a great process. So, until next time, keep breathing.